Hello, everyone, and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Daylight Time. My name is Vic Sinise, and I'm the host for today's show. If you're watching this on YouTube, you can learn more about us by visiting our website at uronurse.com. Our first half hour is going to be devoted to general questions, so feel free to start adding or putting in any questions that you might have. Our second half hour will take a deeper dive into a subject. Today, Andrea Strong will be covering Urology 101, the ins and outs of catheters. Now, to submit a question, simply click on the Q&A button and type in your question. So we're going to do a little different thing today for our start. I have a poll I'm going to send out to everyone. I'd like you to take a minute or two just to fill that out. In the meantime, I'd like to let our panelists introduce themselves and tell us a little bit about themselves. Let's start with Andrea. Take it away.
Hi, my name is Andrea Strong. I'm a nurse practitioner in Milwaukee, Wisconsin. I did work as a urology nurse for about a decade before that. I did inpatient, I did outpatient. I'm certified as a nurse in urology, and I look forward to hanging out with y'all today.
Next, we'll have Lori.
Yeah, hi, everybody. Good morning. My name is Lori Atkinson, and I've been in urology for 24 years now. I'm a certified urology registered nurse and proud to be a part of UroNurse.com.
Thanks, Lori. And John?
Hello, everyone. My name is John Lynn from Gilbert, Arizona, a suburb of Phoenix. I'm a urologist and look forward to bringing value to everybody today.
All right, great. Well, thanks, everybody. Thanks all of you for showing up. We've got a nice group of attendees here. I did find out that I don't think you attendees can see who's all here, but April, welcome, Carol, Claire, Jackie, Jennifer, Katie, Neil, Rachel, Rebecca, Robert, Susie, and Tessie. I see these questions are starting to come in, and I'm going to leave the poll going a little bit longer. Just, we got a really good show for you today. Some interesting things about catheters. A lot of questions have been coming in. Got a few more participants haven't gotten in quite yet, but we got a pretty good number here. Now, this is always a learning curve for me, so I'm going to see what happens when I end this, if I can actually read what it said. Let's see. Good. It does give me it. So the first thing I was asking people in a short answer is where you're coming from. So, whoops. And of course, that one I can't read. It's going to be on my other screen. So I'll go to the next one. How many of the previous episodes have you attended? So it looks like we got a lot of newcomers, or not. I'm sorry, we have one newcomer. It's my first time attending. A lot that have at least seen one episode. The majority. We've got several others that have seen several of them, and even 2 out of the 10 that responded saw 6. So that's great. I'm glad that everybody's coming in and seeing these. So have you ever watched the previous episode of our on our website? That's our uronurse.com website. And 29% of you had said yes. Those that said no, I hope you know that if you go to uronurse.com, you can watch old episodes on our website. And my fourth question was, how did you find out about UroNurse? And that was one I was really curious about. We do advertise on UroNurse Connect every week, just to let people know from SUNA, the SUNA site, and 7 out of 7, 100% found it that way. One of you was learned by a friend. So whichever friend you told, thanks a lot for spreading the word. And feel free to tell all your friends about us. We're glad to get you to join. Number 5, I opened the feed 15 minutes before the official program starts. And as you probably noticed today, we do a lot of chit chatting, and I wondered what you thought of that. And we found that the majority said either I like getting on early and listening to the panelist chat, or I don't join early, so I don't know about this feature. So for those that, and nobody said they didn't want us to chat. So I guess it's a good thing. So for half of you that didn't know you could start early, I do open it up at 1:45. You can get on, make sure that your connection's there, and you're going to see the panelists kind of setting up their mics and stuff, and just some general chit chat. Oh, there is a button here that says share the results. Look at that.
Nice.
so you can actually see what it showed. So as I said, learning curve on some of this stuff, but if you don't try it, you'll never figure it out. So that's why I'm fooling around with it now. I'm going to go to, let's see, I want to see if we have any questions coming in from our group. Nothing so far. Feel free to ask those general questions, but in the meantime, I am going to switch over to a question that I received ahead of time. So you guys can submit your questions before the meeting and we'll give us a little time to think them over. But anyway, this one came in from Katie Bortel, who said, how many silver Foley catheters in long-term patients? How many use silver Foley catheters in long-term patients? And Katie was a research nurse in many studies. So I've actually invited Katie to come in and join us as a panelist in case she wants to do some of her own talking. I'm going to bring her in here. So Katie, if you get the click, just go ahead and click on it and it'll bring you in. All right, Katie, just gotta unmute yourself. So the other thing is I brought the conclusion of what the study that she had sent me showed. And interesting, it said the risk of infection declined by 21% among study wards randomized to silver-coated catheters and by 32% among patients in whom silver-coated catheters were used on the wards. So use of the more expensive silver-coated catheters appeared to offer cost savings by preventing excess hospital costs from nosocomial UTI-associated catheter use. So, Katie, you have any thing to add to that?
Well, the cost of the catheters have come down because I was doing just a little research on it since I knew we would be doing this, because they used to be cost prohibitive, but they've come down. I worked for Medline for about 2 years and I was involved in a lot of the studies, especially I was at Yale. So I worked with the infection control doctor there. I went to Texas and I was through Louisiana. So we were doing several studies and it was interesting how long-term, I'm not talking short-term because, you know, it just seems that you try and get patients off catheters. One of the main things people did is always put in a larger catheter. And I know it's the bane of urology nurses when you see that. But the silver catheter, like silver dressings, I mean, there is a lot of research that proves that.
Yeah. It's something I don't always think about is the use of a silver catheter. Our panelists, since we have a lot of you, if you've got something you want to add to the talk, just put a finger up so I can call on you and know that you wanted to speak about it. Lori?
I was just curious about allergies to those catheters.
Very little. Yeah, silver is one metal like that. There's few allergies. There's always going to be somebody, but there's very few allergies that I had seen. And we did, let's see, probably about 8 to 1,000 patients that we had worked on. There was me and another nurse, and we did the teaching. I did the actual, you know, hands-on, but it was interesting. We saw very few.
And Andrea?
So I haven't used these catheters in practice, but I was wondering if there are any difficulties getting insurance coverage for these.
Not for long term, as far as I know, because they've come down in price. I mean, they are just probably a few cents to $1 more because they've proven it. And since there's so many white papers on it, and they've been using these for many years, they will pay for it, especially long term, because the outcome is a decrease in the infections and complications.
Thank you.
That's a good point. It seems like the cost is offset by the decrease in infections. And we know, urinary tract infection and a hospitalization is a disaster when it comes to Medicare doesn't want to reimburse for hospital acquired infections. So that's great. Again, attendees out there, if you have any questions, this is our general question time. Feel free to submit any questions that you may have. We've got Katie on. If you've got some more questions on her research with silver catheters, throw those in there. If we don't get any questions, that's fine too, because then we'll just move on to our second part of the program, which is our catheters talk anyway. So that's why I like that as a good segue into it.
Vic, I can see that one of the participants had raised their hand.
Oh yeah, Paula Wagner, did you want to say something? You could put it in as a Q&A. We don't have, I can see you raise your hand, but if you type in a question on the Q&A, I'll be glad to bring you in here. Okay, I did see that, but maybe Paula didn't have any questions. All righty.
And for people who are watching, it doesn't have to be catheter related questions. It could be anything that you're encountering in your practice.
Here we go. So Paula Wagner did get her question in here. Often you need a document to get silver-coated Foley catheters covered. So we have to have documentation. I'm guessing a urinary tract infection. Is that right, Katie?
Several. Yeah, you
So
have
recurrent.
to have. Yeah, and also, if a patient is allergic to some of the catheters, I mean, it's coated with silicone, a lot of them. BARDA's making them, Medline's making them, and I'm not sure about the other companies, but there's a few companies that are making them now. And they're not, Foley catheters, we've seen allergies to certain ones, so you got to still be careful. But yeah, documentation for anything. I mean,
Yeah.
that's the key to it.
And are these, try to remind me, are they normally latex catheters with the silver coating, or the silicone that they use?
They're mostly silicone.
Okay.
And, we replace catheters every 30 days just out of habit. But there's some research that shows that the silver catheter can stay in longer. I've read some articles that said that the silver stays on for 60 to 90 days, approximately. Everybody is different, but it doesn't have to be changed every 30 days. I think that's just something that we came up that it should be because of incrustation, and patients should be seen about every 30 days or so, but they've stayed in longer.
Good. Paula Wagner wrote in that in our practice, you can only have a long-term Foley in if you're in hospice. So you know anything about
that? I'm not sure of. There's a lot of long-term rehab centers and everything, that do use the catheters.
Andrea, is your talk addressing silver catheters at all, or?
No, it's not. But I had an additional question for Katie. I'm wondering, is there any research on these catheters having less biofilm buildup, less incrustation?
Yes. I sent Vic another article. I think it's in that. But yeah, it does show that.
Yeah, Katie sent several articles to me, and I'm going to try to post those up on our UroNurse website to have that any research things that you guys send, I can post them there, and you can download those articles to read yourself. So I will include those. Paula Wagner stated, the literature notes that the only cath that can decrease complications is a silicone catheter. Interesting.
Yep. Silicone can be coated with silver, though.
Yeah. I know we're going to have October the 8th. I'll give you a little heads up. I've got a speaker by the name of Todd Thompson, who's a VA nurse, advanced practice nurse, and he's going to be talking about the complicated catheter problems and how they've solved them. And he's got, apparently he said that he's taken catheters that were, clogging in a few weeks and making them last the full time between normal changes. So it's going to be an interesting talk. I think he'll address a lot of this information that we're discussing. And it's important. I think there's, a big concern about what do you do when you have these people coming in every other week with a blocked catheter? What do you do when the bag turning purple? And he's got some solutions. So we're looking forward to bringing him in a few weeks. So be sure to tune in for that one. And if there's any other general questions, catheter questions can probably wait till after Andrea's talk. But otherwise, I'm gonna move it over to Andrea's talk. And thanks, Katie, for coming on board. I'll put you back over to the other side. And Andrea, I'm going to let you go ahead and take over as screen sharing.
Okay. Are you able to view my screen okay?
I can see your screen, but you need to put it into the play mode because we're seeing everything right now. There we go.
All right. So my name's Andrea Strong. I'm a nurse practitioner. I did work as a nurse for many years in urology. I'm currently in Wisconsin, and I'm talking about catheters today. This is a longer presentation. It's about 50 slides, so we're going to cut it in half. So today I'll do part 1, and then in the future I'll do part 2. So here are a few of the objectives. You don't need to read through those. So today I'm going to cover indwelling catheters, specimen collection techniques, leg bag teaching, and specialty catheters. Next time I'll be covering clean intermittent catheterization, suprapubic catheters, and external urinary catheters, and bladder scan. Well, we might have time for CIC today. We'll see how it goes. So indwelling catheters, UTIs or CAUTIs are the most common hospital-acquired infections, and 80% of these are due to indwelling catheters. Urosepsis mortality rates are reported as high as 25 to 60%. So this is really significant, and I think this is a really important role that nurses can play in preventing these infections. So whenever you're placing a catheter, you first want to verify the patient's allergies. If they have a latex allergy, you'll want to use a silicone catheter. These are the clear catheters. And if they have an iodine allergy, you'll want to use an alternative cleanser. Most employers will have a specific protocol that you'll need to follow on what kind of alternative cleanser you need to use. Ideally, you want to use the smallest French size unless indicated otherwise. So there are some scenarios where you want to use a larger catheter, and sometimes that's because the catheter keeps clogging off with biofilm or possibly small stones. If the patient is bleeding or expected to have some bleeding, you may want to use a larger catheter to prevent that from clogging off. If the patient has had any augmentation to their bladder using bowel, that bowel will still create mucus. And in those cases, you want to use a larger French size with a larger lumen to prevent that from clogging off as well. And then you always want to ask the patient if they've ever had a surgery involving the urinary tract. This is really important for our emergency room staff or urgent care staff to ask the patients, because sometimes these artificial urinary sphincters are not addressed. And if you place a catheter with an artificial urinary sphincter that's engaged in the closed position, you can cause damage to the patient's urethra. You could also damage the device to the point where it needs to be replaced. So this is a picture of an artificial urinary sphincter, also known as AUS. So this is generally used for patients who have stress urinary incontinence in males. I understand that in Europe, they're doing some testing on a female artificial urinary sphincter, but I don't think that's ready for prime time yet. But for our males, this is what the device looks like when it's implanted. And the cuff will remain in a closed position so that the patient remains continent. And then there's a small pump that's implanted into the scrotum. The patient can push that button, which will remove the solution from the cuff over to the balloon, opening up the urethra so that the patient can void, and then it will slowly reclose. So if a patient needs a surgery or an emergency catheter placed, you want to make sure that you're either asking the patient about that. If they're unconscious, we tell all of these patients to wear a medical alert bracelet that states that they have an artificial urinary sphincter. Or if you're not sure and you want to double check, you can palpate the scrotum and you'll be able to feel the pump in there for an artificial urinary sphincter. There's also pumps in the scrotum for penile prosthesis as well, but that's another way you could do it in a pinch. And you'll need to have that deactivated by a urology specialist before you place any catheters into these patients. For males, ideally you want to insert the catheter all the way to the Y hub, and that's going to prevent balloon inflation in the patient's urethra. If the balloon is inflated in the urethra or the prostatic urethra, it can cause permanent scar tissue for that patient, which could require future surgeries and procedures. So always check for urine flow before you inflate that balloon. I'll say it again, always check for urine flow before inflating the balloon, and that'll help prevent urethral damage. And whenever you're inserting a catheter or you're teaching patients how to do clean intermittent catheterization, make sure that there's no lint, no fuzzies, no hair, no nothing that goes in with that catheter. If it does, the body will likely form a stone around that piece of hair or piece of lint or whatever foreign object gets accidentally pushed into the bladder. So here's a picture of stones, just to remind you. So indwelling catheters, it's no longer recommended to test the balloon. I did my undergraduate nursing degree a few years ago now, but at the time it was really important that you had to test the balloon before you insert the catheter. And that was even part of our checkoff was, make sure you inflate it to check it. We don't recommend that anymore. And the reason for that is because it's very unlikely that there's going to be a manufacturing problem where the balloon's not going to remain inflated. In fact, I've only ever seen that one time. And if you inflate the balloon and then deflate it, it stretches the material and it can create a little lip around the catheter, which can cause pain or abrasions when it's being inserted. Again, try to use the smallest catheter size possible unless there's a clinical indication to use a larger catheter. And, if you're inpatient or outpatient or in any long-term care facility, if the catheter stops draining and you're not sure, is it clogged or does the patient have low urine output, you can always do a bladder scan with the catheter in to see if it's empty or not. Indwelling catheters, they are color-coded. So white, that little it's like a little circular piece where you inflate the balloon. It will be color coded. So white is a 12 French, green is a 14 French, 16 French is orange, 18 French is red, 20 French is yellow, 22 French is purple, and 24 French is blue. So if you're ever in a scenario where you're not sure, you can ask the patient. If you're triaging a phone call, you can ask them to look at the color or just get a quick visual reference for yourself on those colors. So just to review insertion for indwelling catheters for a male, always pre-clean the site, always retract the foreskin if the patient's not circumcised. Cleanse the meatus 3 times using a new swab in a circular motion from the meatus down. And once the catheter is placed, always make sure that you return the foreskin to its original position. If failure to do so could cause the patient to have some discomfort, and it can create a tight band in that area. So you can use a Coude catheter for males with an enlarged prostate. Sometimes I see Coude catheters used in other scenarios as well, but generally it's for an enlarged prostate. And that helps navigate the anatomy through the urethra. And if resistance is met at the urinary sphincter, a couple tips is you can always ask the patient to cough, which may open that sphincter a little bit and help you insert the catheter. So Coude catheter, for those of you who are maybe new to urology, it has a little curved tip at the end, and Coude means elbow in French. Another tip for those of you who may be new to urology is when you're inserting an indwelling Foley catheter, there's a tiny little bump at the hub. I've got a photo here that points to that bump. That will show you the direction that the curve is facing. So as long as that little notch there is facing towards the patient's abdomen, then it will be in the correct position to navigate around the prostate. We'll move on to female catheterizations. So what's the #1 reason for failed female catheterization? It's poor lighting and poor positioning. So if you're having difficulty, I would recommend getting the patient on a table, ideally one that you could elevate. Make sure that there's really good lighting in the room. You could even place a few pillows underneath the patient's lower half of the body to get a better view of the urethra. If you meet your resistance, the urethra might be kinked due to a prolapse. You could consider reducing that prolapse by inserting 1 or 2 fingers into the vagina, and you may have a bit of an easier time inserting the catheter for a female. So overall, CAUTI prevention tips. So prevent kinks in the catheter. And when you're having patients in the outpatient setting, you're placing this catheter, make sure that they're aware that they're always looking at these catheters. I had a patient recently who came in, they had a stat lock on the leg, and somehow it twisted itself and it was completely kinked off. You want to prevent dependent loops. So when you're in the inpatient setting and the patient's in bed, you have the Foley catheter hung on the side of the bed. Make sure it's not looped around because that can increase risk of CAUTI. Always use a catheter stabilizing device. So they have stat lock stickers. They also have the pieces that wrap around the leg to hold it in place. You want to perform catheter care daily. Don't allow the drainage bag to rest on the floor. And most importantly, remove the catheter as soon as possible. Keep the drainage device below the level of the bladder. I'm sure we've all seen it where patients came in with their Foley bag flipped over their shoulder like a backpack or something. Empty the bag when it's 1/3 full to 1/2 full. Encourage adequate fluid intake, and that'll be about 30 milliliters per kilogram per day, and use the smallest French size possible. As far as CAUTI symptoms, the most common is fever, followed by suprapubic pain. You can also have flank pain, catheter obstruction, altered mental status, particularly in our elderly patients, low blood pressure, and in spinal cord injury patients, you can have those atypical symptoms and sometimes autonomic dysreflexia in those patients. So according to the core curriculum for urologic nursing, you should always change the entire catheter system before initiating antibiotic treatment. And if you're obtaining a culture, then you'll want to switch out the catheter for a new one and obtain the culture from the new catheter. Indwelling catheter removal, make sure all of the fluid is removed from the balloon before you remove it. Sometimes, generally speaking, we put 10 milliliters into that balloon, but you will find sometimes there's 20 milliliters or 30 milliliters. So make sure that it's all deflated before you try to remove the balloon. If you meet a lot of resistance, stop and notify the provider. Sometimes the balloon can crystallize if it's been inflated with saline. Sometimes there's infection that's caused a lot of biofilm buildup. You can also have incrustation. So you'll see these catheters, once they come out, it looks like there's a bunch of barnacles attached to the side. And then the silicone catheter loses balloon water faster, and it can cause a lip that forms on the side as you're removing these catheters. So for general tips on leg bag teaching, keep the bag below the bladder, empty the bag every 4 to 6 hours or when the volume starts to reach 400 milliliters. Clean the daytime bag and nighttime bag. We say warm soapy water and let it hang to dry. I have seen all kinds of different education provided to patients. I've seen vinegar used, I've seen bleach used. So whatever your facility is doing, I think is just fine. Clean the ports with alcohol before reconnecting. And then this is just a little fun fact. Where did the word French size start? It's this inventor. That's where the name came from. And excuse me, I'm not going to try to pronounce his name, but he was also contributed with the development of the modern syringe. We'll cover specimen collection real quick. So don't disconnect the tubing to collect a specimen. Ideally, in an indwelling catheter. Ideally, you want to scrub the sample port with an alcohol pad for 15 seconds, allow that to dry, and then you can use a syringe to pull your sample off of the catheter. Always collect the gray tube first. So if there's an order for a culture and an analysis, you'll want to pull the gray tube first, which is your culture sample. You'll invert the yellow tube 8 to 10 times. And for your gray tube for urine cultures, you're supposed to shake the tube vigorously and then send it to the lab within 2 hours. And this is just a reminder, we've got our gray top here for the urine culture, and he's number 1, or she. So I think at this time, we'll save the specialty catheters for the next presentation. Thank you.
Thank you. That was really good. Oh, good. So you've got us back to our normal view. All right, great. Well, we've got a lot of good questions coming in here. I've thought of a few of my own too. So let's get started with Robert Fulling. Is the only inpatient long-term catheter for ambulatory chronic catheter patients also. That makes sense. Is the only inpatient long-term catheters or for ambulatory chronic catheter patients also.
I think he's referring to silver coated catheters.
Probably back to that silver one. Yeah, that's right. Thanks. And we don't have Katie on right now as an answer, but I'm not sure if they're used for ambulatory at all, the silver. Let's go on to the next question. Sorry about that, Robert. We'll try to get an answer if Katie can write it in. Paula Wagner, you need a large cath for hematuria and clot retention regarding slide 7. Why not just change or irrigate the Foley of poor drainage? Andrea, what do you think of that?
I think I'm understanding the question correctly. Oh, I think you were referring to the bladder scan for a catheter that's in. Yeah, absolutely. You can definitely irrigate it and see if that's doing, if that unclogs the catheter as well. Absolutely. Or you can use a bladder scanner if there's any uncertainty. I think my point was just that you can use a bladder scanner on a patient who has an indwelling catheter if you feel that you need to.
Yeah, that's a good point. Paulus Wagner said, you can also use 1/2 of the speculum if poor visualization of the urethra.
Very good tip. Very good tip. Thank you.
Good tips. That's what we are looking for as far as, is more than just questions. Sometimes is your own personal, what you've seen happen throughout. I have a question. You were talking about putting in a catheter and the waiting till you see the return of urine before you start filling the balloon. Now I've had experience where the gel blocks the catheter, and if they don't have a lot in their bladder, you may not see a return.
Correct. Yeah, I didn't realize that the gel could maybe block it as well. Yeah, that's a tough one. But I would say if you're up to the Y hub, start to inflate the balloon and really make sure that the patient's not experiencing any pain as you inflate that balloon. If they experience any pain, stop and make sure you're not inflating the balloon because it could be in the prostatic urethra.
If I'm unsure, what I do is I'll go ahead and just put 20 or 30 cc's of fluid in there. And when it comes back, usually you'll have a tint of a yellow color.
Yeah, I like that technique too, just to go ahead and irrigate it and make sure that it irrigates. Because I've actually put in catheters where it'll get stuck and fold over on itself. So the tip is actually then aiming out. And then when you try to put any fluid into the balloon, obviously it's kink, so it won't do that. Or if you try to irrigate it, it's kink, so it won't allow any irrigant. It's a good way to tell.
I think going back to Paula's comment, you need a large catheter for hematuria and clot retention. Why not just irrigate? Irrigation is one option. The other is to sometimes simply manipulating the catheter, pushing it in slightly, or maybe rotating it. So maybe the port that is inside the bladder is not possibly blocked by the bladder lining or the bladder mucosa. And sometimes just that simple manipulation will allow drainage of the catheter without any manual irrigation.
Yeah, it's a good point. And Paula Wagner also made a note here, changed position on the legs too. I'm sure that's has to do with the stat lock, whether you have that on the right leg, left leg, or all the time in one leg.
Really great point.
I had a question regarding the stat logs. So we have multiple patients that they don't have that slack from the tip of the penis to the leg to actually put a stat lock without pulling. And a lot of people don't want the extension tubing, or even the extension tubing is probably not going to help, because if you're using the stat lock and you're putting that catheter in a stat lock, it pulls. So I just leave it off and I just make sure that they keep their leg bag above their knee.
Yeah, I would add to that. I just use tape in that case, where you can tape the actual, tubing from the catheter. Rather, the stat lock relies on that little Y port to hook up. So you can tape it below that if you're just taping directly to the tube. But I strongly encourage some way to anchor it so that it's not pulling, so you don't have that constant pressure every time they move. And as somebody who had to wear a catheter, that makes a huge difference. It's just much more comfortable if you don't have that constant pull. And a good point from Paula on the changing the, leg from left leg, right leg. I mean, how many of us out there have seen the filleted penis from the urethral erosion that long-term catheter can cause?
And the excoriation from the stat lock itself. When you pull it off, these elderly are they have very fragile skin. So a lot of times you just want to change it to give it a break.
Yeah. I've been surprised in my practice. There are younger, healthier patients who will have some erosion and some breakdown at the meatus just from like 10 days of a catheter insertion. So yeah, it's really important to alternate right leg and left leg for these patients.
Yeah, good points. Paula Wagner, the bladder scan costs $400 in California. Wow.
Really? Wow.
Maybe at the hospital.
I don't think that's the reimbursement. I'm sure, but I'm not surprised. Yeah, I mean, it is an expensive test.
With the facility fees at the hospital, it may cost $400. The hospital may get reimbursed $400, but that is nowhere close to what private practices get reimbursed. Paula's comment about using half of the speculum for poor visualization of the urethra in a female. The only times that I've had difficulties, granted my experience is not as extensive as most of you, when it comes, I recall vividly being called by the nurses because they couldn't get a catheter in a patient in the ICU during training. And really the only problems are, as you mentioned, Andrea, can't see, so good lighting is important. But it was a morbidly obese lady. The main thing is we just needed more help to retract the vulva and the labia. And once you can see, then the catheter went in without any problems. So sometimes getting extra help because of the patient's habitus may be important.
And I think that even with using a half a speculum, you need help anyway, because I don't know how you do that by yourself.
Yeah.
Well, half of the speculum goes posteriorly, right? You're holding it posteriorly, but then you still have the lateral tissue that obstructs the urethra that's anterior. And sometimes it's not right there. The depth of the vulva is pretty extensive. So you need two people, some people to hold the leg, some people to retract the labia, and then with or without the speculum just to get in.
Yeah, that's a good point. It's rarely obstruction, although some females can have a stricture of the urethra just as much as a male can from previous catheterizations, but it's all visualization. A quick story: when I was an orderly and I was in nursing school, the nurses on the floor wanted to train me on how to put in female catheters, and their technique was put a catheter in, and if it doesn't drain urine, get another catheter and put that one in. And eventually you'll block everything that's not the urethra. And I'm like, that doesn't make any sense. I said, shouldn't we just look for the urethra? Well, you could do that too.
How things changed.
I know.
Paula also mentioned that she also always put in normal saline in the bladder prior to changing the Foley. I think that was Lori's comment, right? To irrigate.
Yeah, well, either before or after. I know that for pubic tubes, I tend to put a little bit of water in first, just because I want to be sure when I put it in, at least I get that return, because suprapubic tubes, when you don't usually get a return if you do it without water. And of course, when you remove the existing catheter after you put the water in, of course, it's going to start spilling out. And that's where you really want to hurry up and get it in. But that's how I do it, just to ensure that, especially for suprapubic tubes, I can get them in.
Especially when that suprapubic tract is relatively new, you want to make sure that it's actually in the right position when you replace the catheter.
Yeah, good point. Paula also made a note that the cath company makes connecting tubing or a belly bag for day use. That's sometimes something that we don't always look for is like the belly bag.
Our doctors, our providers do not like the belly bags for the reason that it's above. It's not really by drainage, so they tend to get more infection, in their opinion.
Yeah.
I have
Go
a
ahead,
few
Ann.
patients who really like to use the belly bag, and I will allow them to use that. I haven't seen personally an uptick in infections with the use of the belly bag. But then I've only been in practice less than a year, so I guess the future will tell. It seems that maybe it wouldn't drain as well, since it's pretty much flush at the same level as the bladder. But some patients really like the belly bag so that they can conceal it easier, and be able to wear shorts out and about without their leg bag showing.
Yeah, I agree. I did talk to the designer of the belly bag and asked that question: how does it drain when it's at the same height of the bladder? And apparently the engineering behind it allows it to drain and not reflux. And I've had many patients that do well with it. I don't know that I've seen any uptick in infections or sepsis or anything like that from it, as well as people using the catheter plugs. The right patient with a catheter plug can have a much better lifestyle than walking around with this bag of smelly urine on their leg, and they do well. It's not for everybody, because some people are not, with it enough to make sure they're draining it all the time.
Yeah, that's one thing I didn't mention in my presentation, that you can plug the catheter and just have them unplug it to drain it. If you really trust them to make sure that they're going to empty their bladder. There's also flip valves that I've seen. So it's just a little, it's like a cap, but it's got a valve on it. They can open it and drain their bladder. Again, make sure you're really trusting that patient to be able to do that.
Have you used any of those items, Lori?
Oh yeah, definitely the flip valves. And we have a fair amount of people that plug them. But again, like you said, it's for those people that will actually do it. You can trust them to do it.
I think the plugs are greatly beneficial for the guy who comes in, new patient, who went into acute urinary retention, most likely due to an enlarged prostate. They hate the catheter. So we switch it. We give the option. Do you want it to continue to drain into a bag, or would you like to try a plug that you have to unplug and drain your bladder on a regular basis? I would say most people want the plug, and we get them in very, very quickly after we start them on medical therapy. And then they will come in for their cystoscopy, transrectal ultrasound, at which time the catheter comes out. They get a voiding trial, but it's a lot more convenient and more comfortable for the patient. When it comes to, go ahead.
Oh, sorry. It's really convenient for people to use the plug when they shower, because a lot of people don't obviously want their bag wet or whatever, and you don't really want it disconnected to shower. So plugging it during showering is great too.
Yeah.
And for the male with the plug, he can kind of tuck everything in under the underwear, and you don't have to worry about something sticking out. It's a lot more comfortable and a lot more convenient. Andrea mentioned something about foreskin and retracting the foreskin and prepping the glands and urethra prior to a Foley catheter insertion. I have some older patients who has phimosis. You can't retract the foreskin. if you are comfortable, if you're experienced enough, I've been able to drive a telescope or a cystoscope through the urethra without any problem. So if you have to, if you're comfortable, if you're experienced, you can try to do the best you can in the skin prep and then insert a catheter without having to retract the foreskin. And if you retract the foreskin, put the catheter in and forget to put it back, there's a condition called paraphimosis where you get horrible inflammation of the skin around the head of the penis, and it's a lot of edema, and it's difficult to pull it over the head of the penis. Let's see, something about saline, to using only saline to inflate the balloon. Studies have been done actually that you don't have to, if you don't have saline, you don't have to use saline to inflate the balloon. It's not going to increase the risk of clotting the drainage tubing for the Foley balloon. And I routinely use saline in the OR when I put in a catheter and like say 30 cc's in a balloon after like say a TURP or TURBT procedure.
Rather than using sterile water.
Or saline, yeah. Rather than water, yeah, I use saline without any issues.
So I'll ponder this question to the group. Have you ever had this incident where you go to take a catheter out of a patient and the balloon doesn't deflate?
Yes. Oh, I have a great story. So
That's
this is good information.
That's a whole.
So, yeah. So of
Go ahead,
course
Lori.
we do the nice cutting of the port, in half, and the water will run out. I had this one gentleman that even though I did that, it still wasn't coming out. And so I went to the provider and I said, what do I do? He goes, don't do anything. Keep the patient here. It's going to deflate and fall out. So the patient just walked around. Sure enough, 10 minutes later, I go in there and it's gone. It slid right out. So it just you need patience, cut the port, and then just wait. It's going to fall out.
Sometimes. Not always.
I've never had one that doesn't.
Yeah, I have. So other option that I've done in that particular situation, you cut it, it doesn't drain, and you've let them sit a while. The thin wire that comes inside those, trying to remember what it's called, the counsels, those things that you pass through scopes.
The glide wires.
The glide wires. You can take the thin wire inside of it and sometimes knock loose whatever's obstructing it with that. That works. The old fashioned thing, because I've been around a while, was to put some ether into the port, and the ether will melt latex. It just pops. The only problem with ether is you got to make sure that you use a glass syringe, because if you use a plastic syringe, it'll melt.
Wow.
But it works. And the most reliable thing, we don't do ether anymore either, is since we have a transrectal ultrasound, is just to pop the balloon with a needle through the ultrasound. You can easily aim at it just as you would anywhere else on the prostate. And it's empty, it's worked because you can see the balloon empty. Tricks of the trade.
Can we speak about possibly bladder spasms? What do when people have bladder spasms, what are you guys doing to help with that? Some people inflate the balloon more, some people deflate it more, some people put a bigger catheter in, some people, obviously check for infection, but what do other people do? Any suggestions?
I will sometimes, instead of using 10 cc's, I'll just use 5 cc's. Sometimes I'll start the patient on an anticholinergic. If it's safe, if they're older, I have used beta-3 agonists like a mirabetril or Gemtesa as well to help calm the bladder down. And in a very rare occasion, B&O suppository in the outpatient setting for acute and severe bladder spasms.
Yeah, I think that's B&O is one of those forgotten old tricks of urology.
I didn't even know they still had them.
There's in certain areas there may be a shortage, like say at the local hospital here, there's a shortage of B&O, but post-op B&O works really well too.
Yeah. Good. Paula put in a couple more comments here. They do a cystoscopic puncture of the balloon. So I have seen that where you try to run a cystoscope through alongside the balloon, the catheter, and puncture it cystoscopically. Nice tip there. A Foley should not be a long-term option. The patient should be taught CIC. And I was going to throw that in as a treatment for bladder spasms too.
Sure. I mean, whenever possible, you want to avoid an indwelling catheter, but not every person is comfortable or competent or has the manual dexterity to insert a catheter. Can I make a mention of the Coude catheter?
Sure.
It is imperative that everyone understands in which orientation that Coude goes into that male urethra. So if you don't know it or don't understand it, have someone show you. The key is if I'm facing you, you want to put the bend towards me like this, and it should go up towards my head. So that elbow should be towards me. So if I'm sideways, it should go in this orientation. It is really important to do that correctly, or else you traumatize most likely the prostatic urethra, or at the bulbar urethra, you're going to enter at the 6 o'clock position instead of going into the prostatic urethra.
And Andrea, I know you mentioned that nub that you keep by the port. A lot of catheters also have a line, and that line should be on top.
Yes.
I think those are the intermittent catheters that have the line. I don't know.
You can even see them on a lot of the Foley catheters too.
Really? I haven't
Yep.
seen it. Yeah. But yeah, that's some good points. Andrea, you talked about the artificial urinary sphincter and deactivation.
Yeah.
And mentioned getting urology, but I think it's if we're all urologic professionals, we ought to be able to deactivate that too.
Yeah, absolutely. And if there's any question, they have a really nice YouTube video on how to do it. So yeah, that's just a really important aspect.
Yeah, just that you know how to make sure you have somebody who knows how to deal with it, because you don't want it compressing on a catheter.
And
Go ahead.
One last thing about male catheter insertion techniques to get the catheter in without a lot of issues is, so there's that valve, that external sphincter, that valve that a man can voluntarily close, which sometimes when you try to put a catheter in, it gets stuck there because of anxiety, because you're anxious, the patient's anxious, and the patient closes off that valve. So some techniques to help him relax are to have him wiggle his toes, or when you know that they're tensing up, ask them to relax their buttock area and relax their legs. If you can feel their legs relaxing, their buttock area relaxing, all you have to do is get to that point and then have them do those maneuvers, and you will literally feel that catheter just plop right in, and then you can go and rest it away. Often the discomfort is at the external sphincter.
Yeah, that's a good point.
Absolutely.
And a lot of times we'll actually have the patients, we'll tell the patients, try to urinate. Just go ahead and try to pee, and then these things will relax.
Absolutely. I agree. Dr. Lynn, that was great. Sometimes when I'm in the patient's room trying to insert a catheter, I'll tell them, release your abdomen, release your thighs, relax your belly, all of those things. And then catheter will go in.
And believe it or not, if you as the practitioner is anxious, your pheromones can induce fear among those around you. So the more comfortable you are, the more relaxed you are. No, literally, that's a survival instinct. So the more relaxed you are, the more relaxed your patients will be. Just like the 22 vasectomies that I have scheduled this morning, the more relaxed I am, the more relaxed the patients will be.
I always said the greatest thing that ever happened to me was gray hair, because patients just have a trust on somebody with gray hair coming in versus some young punk who's, I'm going to put your catheter in today. They figure maybe this guy knows what he's doing.
It is really, really true. The degree of patient discomfort can be relative to the degree of the person doing the procedure's discomfort.
Yeah.
I like to do a lot of talking with my patients, get them on a subject that they like to talk about, and then it really relaxes them as well.
That's true.
These are all great tips, because we do them every day and don't even think about the fact we're doing it.
Yeah.
I had one other thought
Go
about, we were talking about bladder spasms treatments. A non-medical one I think that we don't always think about is biofeedback. And I've had patients do that where I tell them, squeeze and relax your rectum, like you're trying to stop yourself from passing gas 5 times. If you get a spasm, do it 5 times. a lot of times that biofeedback mechanism will relax the bladder spasm. It'll go away. No meds, no side effects, not hard to do.
I like it.
So if there's any other questions from the audience, please go ahead and submit those. If you don't have any questions, we're getting close to our 10 o'clock hour. I would like to invite everybody over to the after party. If you haven't been to the after party, you're missing out. This is, you go to uronurse.com. There'll be a big button that looks like what you're looking at right now. You click on it, you'll be instantly transported to the most fun you'll ever have today. There's a selling, right?
Yeah, it's always fun. Anything goes there.
Just hang out, ask any questions that you didn't ask, you want to ask, or comments you would like to share. You know, we're all going to just kind of move over to that room next anyway, so we'll be there. Looking forward to it. Little preview, next week is going to be ED, so stay tuned for that. And we've got some other good thoughts going on. So I'm in the process of adding a calendar to the UroNurse, so you'll be able to look ahead and see what things are scheduled, and look forward to getting new speakers and covering more product things that you guys want to hear about. So at this point, I'd like to say thanks to all my panelists. You're great as always. Really enjoy talking with everyone. Enjoy getting together. So we'll see all of you over in the other side at the after party.
Thanks, Vic. Thanks,
Bye,
everyone.
everybody.